I'll be quickly sharing with you an important aspect as far as the predictors of outcome. I mean, when we are dealing with a case of catheter-directed thrombolysis for an acute iliofemoral DVT, we are in need of so many information about the outcome of our success. It's not about the, usually, it's not about the angiographic success, but rather about the clinical outcome and identifying predictors of good or bad outcome, actually. So that being said, I have no disclosures. By the way, this is a humanitarian mission. Last week I was in Indonesia, and it was very enriching having this humanitarian mission, volunteer mission, treating patients in Indonesia and supporting and training the younger generations. And that's the essence of our presence as older generation, to support and train and keep training the younger fellows. And that's what we are trying to do right now, because in the audience, I can see so many of the younger generations. Objectives of treatment of acute DVT are well known to all of us for the sake of time, so I'll be running over some slides. What we need actually is to try as much as possible to preserve the valves. It's not about lysing the clot, but preserving the valves as much as you can. We need to prevent the pulmonary embolism threat, and we have to abort that, and to try to slow down the occurrence and frequency and severity of the PTS. So, excuse me for being quick in some of the slides. Well, we know that catheter-directed thrombolysis has by far replaced other techniques, especially in tertiary reference centers. Okay. Difference between the heparin therapy and catheter-directed thrombolysis also are well known in favor of using catheter-directed thrombolysis, because we try to dissolve within the traditionally, arbitrarily mentioned in the textbooks cutoff value of like 2 weeks. But personally, and I think some of our colleagues and back home at Ain Shams, we have had 24 and 26 days of successful lysis. We'll see how to quantify the lysis. This is very important as well. So we have a pile of published papers in the literature. However, as far as DVT is concerned, we have to classify the DVT. Is it acute, subacute, or chronic? And that has an impact on the treatment policy and strategy, of course. Indications are well known again to everybody. We have to follow the NIH guidelines in case there is a risk of bleeding higher than usual in this specific patient. And as far as predictors of long-term outcomes, so many published papers in the literature, degree of iliac vein stenosis and the time from the onset to treatment, but that's only one aspect. So thrombus score at the beginning is very important, because we will see at the end with my take-home message that the degree of lysis achieved in the first and best timing of the sessions is important as predictor of outcomes. Not only the burden, but how much lysed from the very beginning in the first session, because this is an indicator of how severe the PTS will be. There are 7 venous segments, starting by IVC and ending by the popliteal vein, that we have to know the burden of the thrombus over there. That's our registry. I'll go quickly through it. We were able to follow up 20 patients in the phase 1. And those are inclusion criteria, and those are the endpoints. I'm going quickly. Careful about that, because I'll come back to this at the end. Technique is well known to all of you. Parameters of follow-up is the degree of lysis and whether PTS is diagnosed after 6 months of follow-up. Of course, one would argue here, but PTS can happen after 2 or 3 or 4 years. We are aware of that, and we are aware of the limitations of our study, of course. And these are our results. Categorization of bleeding is, of course, very important as well. Caval or non-caval involvement. Ironically, in our series, involvement of the vena cava was a favorable predictor of a good outcome and not the opposite. We don't have do not have a direct explanation to this. Probably Marcus later on would have a comment on that, and the rest of my co-moderators. Then, so of course, I'll go quickly to this. Some of our cases, pre and post, and I'll go quickly in this. And this is the final result. And after CDT and standing as well. Again, some of the publications. Limitations of our study were the limited number of patients and the poor compliance of the patients, especially for the follow-up. We are aware of those limitations. Again, I won't dwell on the ATTRACT and the rest of the well-known studies to all of you and the trials. So my first take-home message, having said that, we have to differentiate between a sort of acute failure or short-term as well as the long-term failure. Which thrombolytic agent, in fact, this doesn't matter. It's about the dose and the degree of lysis you have achieved. So alteplase or retiplase, it doesn't matter. In fact, it's about the dosage. The protocol is there for everybody. So take-home messages, both anticoagulation and catheter-directed thrombolysis are efficient in the acute phase, but it's about the preservation of the valves, again the valves, and the degree of the PTS. So those counts. And again, I would like to thank you so much for your attention.